The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're very fortunate to have Professor Dedee Caplin back with us this week talking about management of pain. This has been very fascinating so far. Welcome back, Dedee.
Thank you. Glad to be back.
Have you developed any conflicts that you'd like to share about this week?
There's still nothing.
Okay. Let's dive in. So we talked a fair amount last week about the various domains, those domains being physical, functional, social, environmental, psychological, and cognitive behavioral. We talked about evaluating those things. We wanted to expand a little bit this week. We talked last week about expectations of what we ought to be doing, but we wanted to maybe make some specific recommendations this week about things that we could potentially do to help our patients. Wanted to talk a little bit first about, you shared some information with me as you sent me materials about this, about some treatment specific. Tell us about the stages of change, because I think it's important for us to be aware of that and to be able to read that to some extent.
So I think the stages of change is more of a theory that kind of frames your understanding of patients and families much more than it is like treatment. But where it lends itself to treatment is that depending on where a person is in the cognitive understanding of change and the change process, they may or may not be ready for some of the things you're asking them to do. Oftentimes when, for example, I am treating patients in the hospital and I come in and the very first time I'm meeting the patient, the consult question is, can you teach them how to manage pain so they can go home and get out of the hospital? And my answer is, well, it kind of depends on where they're at in that process. And so the stages of change theory is just a way to frame kind of where am I meeting this patient and how do I meet them where they're at. The stages go kind of pre-contemplation, contemplation, preparation for change, action, and then maintenance of change. And in the contemplation and pre-contemplation phase is where we meet a lot of families. When a family comes in for a physical complaint, and you suddenly start to bring up the idea of function, the idea of psychological factors, the idea of cognitive factors or environmental factors, you have to give that patient an opportunity to contemplate what that then means for them and what that means for their illness and their understanding, but also how does that then frame into what you're asking them to do? And I think that sometimes patients and families don't even know that they have any capacity for control. And so the idea that suddenly it's like, oh, we're going to give you all these things to treat it. And it's like, whoa, 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 I can't do anything. I just told you I can't do anything, really becomes like too early and too often. So as a clinician, really understanding kind of where your family is in that understanding process and in contemplating what their role in care is can really help you frame kind of where you start with them therapeutically. Like, do you start with listening and education because they are in that pre-contemplation phase and contemplation phase, like helping them understand what the problem actually is, or how does pain work in the body, versus a patient who is like, okay, yes, I want to do something. I want to go back to school. I want to get this happening. You're going to treat them a little bit differently.
And when we talk about therapeutic options, there's really an implication that we're going to work out with them what they can do, that this has to be something that they feel they can do. I was thinking before that, this is a lot different from what we do, for instance, if we're treating strep throat, but it's really not, because when we're treating strep throat, there's the implication that I've made this diagnosis and here's what I'm asking you to do. Is that something that you think you can do? And so if I give a bottle of pills to an 18-month-old, I've missed the point. That's not something that they're prepared to do. Right. And so I have to work out with them what their capabilities are and what I can offer.
I think you'd be hard pressed in medicine to find a disorder or a treatment that you're not asking for behavior change. Like, I would find it impossible, actually. Maybe a sedated patient that you're doing everything for in the ICU.
Surgery. Yes, surgery once the surgery's begun. Yeah, maybe. Yeah. Well, let's talk about these domains again. So the first domain is physical domain, and treatment goal is that we're promoting health and managing the symptoms. What sort of education do you think is most important for people to have about that?
So I think a lot of the goal for treatment is promotion of health and promotion of function, right? So anything that helps you teach the patient how to get to that goal, what's the space between here and there, can be helpful. With pain specifically, understanding your autonomic nervous system is a really helpful tool for a lot of patients to understand why we're asking them to do the things that we ask them to do. I will often explain pain pathways, how pain is regulated in the body and the brain. And I can use simple analogies. If I stomp you on the foot, there's a whole bunch of nerves that go up to your brain. And your brain says, oh my gosh, what is that? And it knows what to do because it interprets it as pain. If I stomp on your foot, but we're in a swimming pool and the water's really cold and we're playing, those signals are still flying up to the brain, but the response isn't necessarily going to be the same because the attention's not the same and the stimulation is not the same and the environment is not the same. And so again, helping kids understand those nuances can be really helpful in getting them to understand why certain behavioral techniques will actually help them out. And then I think the bigger thing is helping people understand you can have an illness without feeling sick. Sick is a feeling. I feel illness is something you have. So if you have a pain disorder, if you have diabetes, if you have anything, it doesn't mean you're sick all the time. But a lot of times these kids are in a space when we see them where they feel sick all the time. And so how do we teach them that difference and helping them understand we can get them here? They might still have a pain disorder, but it doesn't mean they have to feel bad all the time.
Excellent. Let's talk about treatment. One of the reasons I want to talk about treatment is you have a mnemonic device here for treatment. The SMART intervention.
Oh, I was like, yeah, I was like, what mnemonic? Oh my gosh, sorry. Yes. So it's not my mnemonic. I stole it from one of our headache doctors. But yes, the SMART mnemonic is really it's kind of our level 1 treatment approach, right? Your body is not going to work unless you know what it looks like when kind of it hits homeostasis, when you've got everything going the way you need to go. And so the SMART mnemonic really is kind of around that. So it's the S is for sleep, the M is for meals and snacks, the A is for activity and exercise, the R is for relaxation and stress management, and the T is for management triggers. And so that's kind of where the SMART comes from. And I feel like every kid in the universe has been told to drink more water at some point in time, or get 9 to 11 hours worth of sleep, or get 30 minutes of physical activity several times. What I've noticed is that unless kids understand why we're asking that, oftentimes it's hard for them to do, or they think it's stupid, or they think it's something that you say to everybody because they've heard it. And therefore, it's just your standard response rather than something that's directed at them. So if you are going to work with a patient on, management of nutrition and hydration and sleep and activity, help them understand how that helps that pain response. How does it help your body's response to pain management? How does it improve your tolerance for activity? Sleep is a good one. I think sleep is something that I talk about more than just about anything else with kids when it's not going well. It's one of those things that if it's going well, you never bring it up. But the minute it kind of falls by the wayside, it really does affect everything else. And so just telling a kid, I need you to get 9 to 11 hours of sleep doesn't get at the problem. But if you say to a kid, hey, 9 to 11 is kind of the A+ range for sleep, where are you at right now and what's getting in the way, suddenly you have some really nice targets for treatment, right? So the kid who can't fall asleep, for example.
I've said here before that I tell adolescents all the time that they panic if they leave the house and their phone doesn't have a complete charge, but they leave the house with a 40% charge on their brain all the time and then wonder why they get an hour by 2 in the afternoon.
Absolutely. And teenagers specifically love hearing about things like the idea that a sleep cycle changes later in the night than it is earlier in the night, that the restorative sleep comes from repeated cycles. So that's why your 8 hours can't be a 4-hour nap after school and 4 hours at night, right? You have to get it consolidated. And so just having those conversations and treating them like a partner in care, I think can really get them into the space where they're actually doing those things. But a kid with good sleep is doing so much better with pain management.
And if you slept 18 hours last Saturday, that doesn't mean 3 hours the other nights is sufficient.
So I do have a comment for that for just about every kid. I say the range is 9 to 11. If you go below or above, you're probably doing something that is counterintuitive for your body.
Another thing that you've pointed out, and that's that graduated changes are probably more achievable.
So not just more achievable, it's kind of necessary for change. Like quick change really falls by the wayside quickly. And the literature, the adult literature on weight management really kind of highlighted this a lot for all of us, in that when change happens very quickly, the body can change kind of on the surface, but at the level of the neuron, at the level of the nerve, those new processes aren't being reinforced enough to actually provide sustained change. And so change has to happen slowly with a lot of steps in the process. The other thing that we're trying to avoid is kind of those big crash and burns that kids in pain tend to do. They have a day where they feel good, they do way too much, and then the next day they feel miserable and are out for 4 days. And so that kind of all in, all out cycle is really detrimental because you're not teaching your body anything other than there's no middle space.
But also, if you succeed in doing a little bit more, that's a lot better feeling than crashing if you try to do a lot more.
It is for some kids. Like it kind of depends on where they're at in function. Like I have kids that I've met, and this is by no means the vast majority, but I've had kids that I've met who really spend 20 hours a day in their bed. And, so our very first goal might be, I actually need you to be out of your bed during waking hours. And some kids are very offended by that goal. Like, what do you mean? And it's like, oh, we just start where we're at. It's like you're in a car accident and you're learning how to walk again. We start wherever you are. And this is where you're at right now. And so again, it goes back to that, where do I meet a kid where they're at and how do I help them understand, those little spaces in between are going to feel like high five worthy as long as we keep moving along.
Let's talk about the functional domain. And our treatment goal, of course, is functional improvement. What sort of education do you think is important for patients?
I think helping families understand the process of deconditioning is really important. And I think this is something that my physician colleagues do very well. They understand the process themselves. Like if your body hasn't done anything for a while, it's like a rusty bicycle. And we know we got to oil it up. We got to take care of things. We've got to, make it move in very safe and comfortable spaces before we can kind of go out on that 8-mile bike ride. And so there are a lot of analogies in natural life that really talk about deconditioning and pacing for growth. And you can use any of those analogies. And most kids have one of those analogies in their brain. They've done it for something else. So just kind of taking their language and using their experience and really kind of pointing them in that direction of paced growth to get reconditioned really helps them understand kind of where you're coming from and why the process is going to take a while and why the process is going to be slow.
Let's talk about the social environmental domain. The treatment goal here, of course, to have a healthy social and physical environment. So what education is important there?
So this is where you want to give families a job, right?
Yeah.
It's funny. So some of the techniques we use specifically for regulation of pain. So I have a really bad headache. The first thing I'm going to do is lower the lights. The second thing I'm going to do is create a quiet or comfortable space. I might turn a fan on my face. I'll put an ice pack on the back of my neck. And then I get to that place where my brain is starting to slow down and those nerves are starting to slow down and they're firing. And my mom comes in and says, hey, rate your pain for me. I have to think about my pain to answer the question. And so I talk to parents about that. I'm like, you want to make sure that if you're asking questions about how your kid is doing, you're doing it in a way that is helpful. And so teaching parents, ask your kids how they're feeling, but don't use the word feel, don't use the word pain, don't use the word hurt, don't use the word headache, but ask them all you want about how they're doing.
Wait, so Pictionary?
No, this is where the word comfort comes in. So if I had my way, we would never, ever use those traditional 0 to 10 pain scales because I feel like everybody knows their number, right? My pain number is this, and it's such useless information for chronic pain. What can you do? Like, do you hurt enough that you're curled up in a ball in bed, or do you hurt enough that you can get out of bed and you can do stuff? Do you hurt enough that you can go to school, or do you hurt enough that you have to stay in bed? And, to me, we're all kind of primed to asking questions about pain and putting focus on pain. And we know that focus is making things worse. And so especially for families and teachers and caregivers of any kind, really helping them understand you want to keep that kid focused on doing, but you're doing it in an empathetic way that if they are hurting, they feel comfortable telling you, you know what, this is a little much for right now. And how do we scale it back? Because there is a role for family in care and there is a role for family in treatment. And so when I'm working with kids, a lot of times it's, okay, we're going to pace back to school. And that means every day for the next 3 days, you are going to be there for at least 1 hour and then take a break. And let's see how that goes. And then we tell the parent, okay, they're going to do this for 1 hour and then take a break. Your job is to help them get through that hour. Your job is not to go pick them up before the hour's over, but to help them come up with what's the right thing to do in that moment to keep you in that space.
Anything to do with the friend domain for this?
So friends can be a wonderful distraction. And I think there is this misnomer that a child in pain can't have fun. And if they have fun, they must not be in as much pain as they thought they were. And I say it's a misnomer. It's a myth, right? Like distraction is a very fantastic pain management tool. We all use it. It hurts, so I put an ice pack on it. I watch TV so that it lowers the volume in my head and distracts me. Friends are a wonderful distraction. Friends are a fantastic diversion. And we know that pleasant activities are going to lower the pain volume in our head, right? So of course, anything you can do with friends, anything you can do with social activities is going to be really important. But again, pacing it. And this is where kids don't do a great job and are going to need adult support. Don't go out with your friends for 12 hours and then not do anything else for the next 4 days. Go out with your friends for an hour, come home, see how you're doing, try it again for an hour and a half, and you get to the place where it'll work better, but it only is going to work better if you're pacing it the same way you're pacing everything else.
And pacing, again, seems to be one of the key features here.
Yeah, it's kind of the golden rule of pain management.
Let's talk about the psychological domain. And here the goal is to have positive emotional regulation and distress tolerance and coping. What education do you think is most important there?
I think the first thing is definitely diagnose and describe and help families understand any mental health concerns that you have uncovered, right? And some of that might be through screening. Some of that might be through history. I know that I've always had anxiety. Now I have, chronic headaches, and helping them understand it turns out emotion and pain feed off of each other in an ugly way sometimes. And so making sure they understand you are more prone to worsening headaches when you have days where your emotions are feeling out of whack. And the other way is also true. And I think about them as kind of like threads in a blanket rather than one thing causing another. When they weave together, they're stronger. And again, they're going to feed off of each other. I rarely, and I want to say almost never, believe that one is causing the other. I almost always see that they're connected and that they feed off of each other. But it's fairly rare for me to kind of be able to draw that straight line that one is causing the other.
And probably completely counterproductive to try to see that one is causing the other.
Yeah. And I think this is where a lot of people slip up, especially if they see both. Our brains naturally go to, oh, I know what this is. You have belly pain because you have anxiety. And it's like, no, you have belly pain and anxiety, right? It's okay to have both.
Using old cultural references, I can name your problem in 2 notes. And that way I don't have to listen to the whole song. And it's our loss, and it's our patient's loss if we haven't tried to see all the dimensions. What other things would you recommend for treatment there? Because
so treatment-wise, I mean, if it's a clinically significant disorder, I would certainly recommend treating the anxiety, treating the depression, anything psychologically that's going on. If it seems to be a little bit more like health anxiety, that child's doing fine, but the anxiety kind of creeps up when they have a pain flare or something like that, then what you can really do is talk more about those pain coping tools. Like, how do we do something in the moment that gets your mind towards doing something rather than just feeling? Because when you're feeling your pain, you're triggering those anxiety symptoms, and then they're both climbing. And so how do we create a situation where you feel the pain, you do something, you feel the pain, you do something, and that do something might be resting, but it might also just be grabbing an icy cold drink. It might be calling a friend. It might be stretching, right? It doesn't have to be like a fancy tool that nobody has access to, right? It can certainly be something fairly simple.
And sometimes intuitive.
Yeah.
Yeah. Okay, let's talk about the cognitive behavioral domain, with treatment goal here being that you have adaptive, sustainable behavior and cognitive change.
Mm-hmm. Yeah. This one I think is the one that is like the hardest to treat, because you have to be comfortable enough saying to families, hey, the way you're thinking about this seems to be interfering with your getting better, right?
Mm-hmm.
And I think that if we can be comfortable saying, when we think about things in a way that leans us toward function, that leans us toward being able to do something, we are actually working for our body instead of against our body. And what you think determines what you do determines what you think. And so if those things are rolling in the wrong direction, it's pretty clear that people are struggling. If, however, you can get it kind of moving or rolling in a more positive direction, or at least a more productive direction, where, a patient says, okay, I have a pain flare and ow, that hurts. It hurts a lot more than it did. Oh, when it hurts like this and I can't do something, this is the first thing I'm going to do. This is the second thing I'm going to do. This is the third thing I'm going to do. Suddenly you start to kind of roll them into, this is my pain coping plan, or this is my comfort kit, or these are the three things I do when I'm in pain. And you actually are coaching yourself and reinforcing that process over and over again. So that's nerve reprocessing. That's really what it is creating that space for change, just by continuing to say, I'm not going to accept the nerve processing that's going on right now. I'm going to challenge it with some other sensation. And starting with sensory tools, like really simple things that you can do to alter sensation, can really be the most helpful in that process.
For instance, what sort of sensory tools?
Ice pack.
Yeah.
So, if you think about your five senses, right? Mm-hmm. Basically, when we have pain, if you think about pain as kind of that sixth sense, sensation of pain is filling up our brain, filling up 4 lanes of traffic, right? You're on a super highway and it's all pain. Anything you do that engages one of your other senses in a strong or simple way can actually just set up a roadblock that lowers the volume of that pain signal. So something like an ice pack can be super helpful. So if you go on, like, for example, the American Migraine Foundation has the 15 best ice packs for headaches. Well, why are there 15? Because people process differently, and different ones are going to work better for different people, right? Some kids think ice burns, and so trying a hot pack instead, or a cool shower, right? But what you're doing is altering and changing sensation. Lots of kids use spicy mints. Here at Primary Children's, we use Warhead sometimes. Like, suck on the warhead while you're getting the LP, and my guess is you'll be able to tolerate it, right? So we create these spaces where tolerance becomes the goal, and being able to manage in the situation without feeling overwhelmed by the pain.
Mm-hmm. Anything else you want to share before we're all done for the week?
No, I think it's really the ultimate goal of all of our treatment is to pull the danger out of pain, right? To remind people in a number of different ways that because pain naturally triggers fear and danger, we really have to kind of pull away from the danger and fear part and remind them that this is just a process, that their brain is misfiring, and that we're really trying to correct.
Well, it feels to me like a lot of the fear it comes from helplessness as well. And I think being able to have something to do that really works, I think, is an enormous boon.
Yeah, no, absolutely. Anxiety hates things to do. That's what we always say. Anxiety doesn't like a plan.
Busy hands are happy hands, isn't it?
There you go. How many analogies, how many phrases, how many cute little stories have been made around this topic, right?
Right. And let's be honest, all those phrases are just designed to try to articulate something that people are just trying to pass along. Well, thank you so much for your expertise over the last 3 weeks. I'm sure that there will be a lot of questions, and we'll plan to address those questions next week, if that's okay with you.
That would be great. Thank you.
Thanks so much for your time. I fear that we would probably do well to spend weeks and weeks on this, and I hope you're willing to come back at some point and talk about some other things. It's been a delight to talk to you the last couple of weeks.
I would love it. This is actually kind of fun.
All right. Thanks, Dedee. Thanks to Elisa Stoddard for making this sound like a podcast. Thanks to our listeners. Please recommend us to your friends and colleagues. That's the only way that people find out about us. Thanks to Janice for listening, and we'll talk next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Paul Wirkus, who also composed the theme music. See you next time.